Well, good morning. As you know, this gets picked up for a broadcast, so we're going to just start on time for the sake of the television studios, and people can come in as they come in during the day. I just would like to introduce myself to you. My name is Dellon, and I'm a plastic surgeon, and I have the privilege of being professor of plastic surgery and neurosurgery here at the University of Arizona. When I'm not here, I'm in Baltimore at Johns Hopkins University, where I'm in private practice. I'm a professor of plastic surgery and neurosurgery there. I'd like to talk to you today about a subject that affects literally tens of millions of people in America and many more than that throughout the world. I'd like to talk to you today about the evidence related to relieving symptoms, relieving pain, restoring sensation, preventing ulcers, preventing amputations in patients who have diabetic neuropathy and superimposed nerve compressions. There is plenty of evidence to support this, and I'd like to go through with you the basic science and clinical evidence. First, I think some of the facts that you should know, if you do not already, is that ulceration will occur in 1 out of 6 diabetics. Typical ulceration may cost $25,000 to heal. If you have an ulceration, 1 out of 6 people will have an amputation, and the amputations can run $40,000. There are probably 90,000 amputations a year in the United States today that are unrelated to vascular problems, but due to diabetic neuropathy. And if you have an ulcer in one foot, within 3 years, half the people will have an ulcer in their opposite foot. And half of these people will be dead in 3 years. The costs for caring people with diabetes and obesity have been predicted to bankrupt the Medicare Trust Fund by the year 2019. If we can do something to save these costs, it would be greatly appreciated. But what is the evidence that we can do something to help save these costs and relieve the pain and suffering associated with diabetic neuropathy? In the level of evidence today, the lowest level are anecdotal. And I'd like to give some anecdotes. After I finished plastic surgery, I became a hand surgeon. And patients with diabetes have a very high likelihood of developing carpal tunnel syndrome. This is numbness and tingling in your hands and bothers people at night. And I would operate on one hand, and the people typically get better. Perhaps 9% of the people get better. They would come and have their opposite hand fixed. Patients with diabetes would say to me, "Dr. Dellon, you help my hands, can you help my feet?" And as a plastic surgeon and hand surgeon, I wasn't quite sure what this meant. And as you begin to think about diabetic neuropathy and how it affects the feet, the symptoms are very much like what happens to people with problems in their hand. I had to look at authority. What authority figures tell us about the hope for preventing neuropathy or reversing it? Dr. Peter Dick, Chief of Neurology at the Mayo Clinic, has been our lead authority on diabetic neuropathy for probably 4 decades. He does not believe that diabetic neuropathy can be reversed, nor do we currently have medical treatment for diabetic neuropathy. The American Diabetes Association, in its most recent publications, have the same conclusion. In fact, the primary way we are to treat diabetic neuropathy is maintaining the glucose level the best we can. And for those with pain, Dr. Bolton, the leading authority from England, and Dr. Aaron Vinnick, one of the leading medical doctors treating painful neuropathy today, suggest the medications you see and that are so well known. Authority says that each patient with diabetes should have sensory testing to determine when the neuropathy exists. And I'd like to show you that I personally have been involved in sensory testing for a long time. Tuning forks were something I introduced when I was still in medical school for the use of peripheral nerve problems. I was the first to introduce the vibratory testing with tuning forks for peripheral nerve problems, and the biothesiometer, which had been used just once for studying uremics, was actually introduced by me in 1983 to study peripheral neuropathy problems. So as a plastic surgeon and hand surgeon, I've been very involved with making measurements of sensation. Doctors today are supposed to use these thin nylon filaments, typically the 5.07 one, which applies 10 grams of force. This number is a logarithm. If someone goes from a level of 2, which might be normal, to 5, they're actually 1,000-fold worse. These little filaments are actually very insensitive and do not make a true measurement. They estimate for you a range. Two-point discrimination is actually related to number of nerve fibers in a small area, and we've been using devices to measure two-point discrimination for a long time. There are real problems with these tests, however. Vibration as a wave travels across an area and cannot truly identify a single nerve. The monofilaments do not give us an actual measurement of a threshold, and two-point touch does not say how hard we are applying that pressure. And accordingly, around 1989, working with an aerospace scientist, we developed the pressure-specified sensory device. This is something that I've invented and do have a proprietary interest in, and tell you that under the conflict of interest concept. But going back now more than 10 years, we began to introduce this device to measure pressures and thresholds in diabetics with and without ulceration, in diabetics who have nerve compressions in their feet, and helping us decide about nerve compression in the upper extremity. So when my patient says, Dr. Dellon, you help my hands, can you help my feet? What should I say to them? Sadly, again, looking at Dr. Bolton, the leading epidemiologist and diabetologist in the world today, I think he's recognized as that, he'll say, we have no way to treat diabetic neuropathy and no way to prevent it. Dr. Dellon, you help my hands, can you help my feet? Well, why shouldn't the work that we do in the hands help the feet? If I can decompress a nerve in the hand in a diabetic and relieve symptoms, why can't I do it in the feet? Maybe if we do that early enough, the neuropathy that is progressive and irreversible can be changed. And that was the concept under which I began to work. Let me share a few case studies with you. Can the symptoms that we think as being diabetic neuropathy be related to nerve compressions in patients with diabetes? And in 1987, I began to look at the tarsal tunnel. The tarsal tunnel typically is just this region and was said to be the carpal tunnel. But actually, with research, we find that the tarsal tunnel is not the carpal tunnel. It's the human forearm. And if we go a little farther down, we see a muscle similar to the thinner muscles in the hand, but it's a muscle to the toe. And underneath that is another ligament and two separate tunnels. This one, the medial plantar tunnel, is the same as the carpal tunnel. This one, the lateral plantar tunnel, will be the same as the ulnar nerve at the wrist. And I developed an operation to release 4 medial ankle tunnels, not just tarsal tunnel, but identifying the medial plantar tunnel, the lateral plantar tunnel, the calcaneal tunnel, and removing the septum between them. And when we do this, and this is a foot in surgery, we can actually take our finger and go from the tarsal tunnel into the plantar aspect of the foot. When this decompression is done, we can restore sensation and relieve pain in people with compression, whether they're diabetics or not diabetics. The common perineal nerve in the knee is another area where there can be pressure applied. And when pressure is applied to this region or the deep perineal nerve over the dorsum of the foot or the superficial perineal nerve, we can have loss of sensation in the top of the foot and the leg. And here, for example, is the knee. Here we've released the fascia over the common perineal nerve. I'd like to show you the common perineal nerve in someone with type 2 diabetes. The knee is here. This is the back of the knee. This large yellow lipoma-looking structure, sadly, is the common perineal nerve, normally a beautiful white nerve. This is the fascia of the hernius longus, and now we will release the pressure above and underneath. And here is the narrowed, compressed nerve. Here over the dorsum of the foot, we can again see a narrowing and depression within the deep perineal that has been compressed. If we take these 3 separate areas, we can get a stocking distribution for sensory loss in the lower extremity. And so in this patient who's 65 years old, who's already had decompression of the carpal tunnel, the ulnar nerve at the elbow, the radial nerve, and actually in both of his arms, when he finally said to me, can I help his feet? I said, why not? He had evidence of localized nerve compressions when you tapped over the tibial nerve in the tarsal tunnel. The common perineal nerve was tender at the knee. We identified superimposed nerve compressions. This large bandage is the dressing we use. The patient will walk immediately following surgery. Here's someone in the recovery room smiling. You'll notice the bruise on the side of his face. With loss of sensation, loss of balance, there are falls, there are fractured wrists, broken hips, and the morbidity and cost associated with that. Here in the recovery room, as his wife tickles his foot, we see the patient smiling. half the people will have sensory recovery occur due to a reversible ischemic block, meaning the nerve fibers have not been working, but they also have not quite died yet. And when we restore blood flow to the nerve, there can be immediate recovery of some of the sensory loss. So we formed the hypothesis that the symptoms of diabetic neuropathy in some patients are due to compression of peripheral nerves. And if this hypothesis were proven to be true, we would have a happy situation. It would mean that the symptoms of diabetic neuropathy in some patients, those with superimposed nerve compressions, are reversible by decompression of peripheral nerves. And here's another woman smiling as her sutures are being removed. In 1988, I formed this hypothesis that we could have an optimism in diabetic neuropathy, and we've been working now for more than almost 20 years towards this goal. What do medical specialists like Dr. Vinnick and Dr. Bolton actually think about entrapment neuropathies in diabetics? They've recently reviewed this entire area. They think that probably a third of diabetics have superimposed nerve compressions, and if we take the top three for the hand, we get a glove. If we take the ones for the leg, we get a stocking. So it's conceivable that by decompressing multiple peripheral nerves in patients with diabetes that have superimposed nerve compressions, we can relieve stocking and glove sensory changes. I began my first series of patients with this and reported them in 1992. What do I mean by diabetic neuropathy? I mean patients who have a large fiber, distal, diffuse, symmetrical, sensory motor polyneuropathy. That's typically the most common form, and it's pretty much what everybody means by diabetic polyneuropathy. Here's what I'm not saying. I'm not saying that all diabetics with neuropathy should have a nerve decompression. I'm saying that diabetics who have a superimposed nerve compression should have a nerve decompression. Unfortunately, particularly the neurology community has chosen to misinterpret the many papers that I'll show you coming up. We are not saying that every diabetic with neuropathy should have an operation. We're saying that if you're a diabetic and you have a nerve compression, that nerve should be decompressed. Our first paper was published in 1992. It had 60 patients with diabetes type 1 and type 2. All patients have a positive Tinel sign. That means when you tap over the nerve, you'll get a tingling into the distribution of that nerve. None of the patients chosen in our first group had had a previous ulcer or amputation. In that first study, the majority of patients had had preoperative electrodiagnostic studies with a variety of diagnoses given by. We operated on upper and lower extremity nerves. On average, the follow-up was 2.5 years, but the longest follow-up was 7 years. And today we would call this an outcome study where the patients were asked if they were happy, would they recommend this, would they do the operation. Again, every colored dot is a different nerve. 80% of these dots are above the line, meaning they've had a good or excellent result, whether they're type 1 or type 2 diabetics. And here are many diabetics who've had diabetes 20 or 30 years who could still be helped. Here's a typical example. This patient was operated on in 1984 and 7 years later has had no ulcers, no amputations, and has sensation still measurable in terms of 2-point discrimination. 88% of those people were better. One patient had worse motor function. 10% were not improved. In that first study, I did obtain postoperative electrical testing, and 100% of those in whom the pre-op electrical test said there was a localized compression were better electrically. 80% of those whom the pre-op electrical test said they had neuropathy and superimposed nerve compressions were better. And even 50% of those that had a diffuse peripheral neuropathy as the diagnosis were improved electrically postoperatively. Importantly, none of those patients developed a new ulcer or amputation. And importantly, half the people had worsening of their symptoms in an opposite limb. Remember, the expectation is that neuropathy is progressive and irreversible. And so in a limb that we didn't operate on, we expect that limb to get worse over time. So while 88% of the operated extremities improved, half of those not operated upon became worse. After doing that work, we went to the laboratory to see what actually was going on and how we could help understand this level of evidence at the basic science level. And we began work on the pathophysiology of nerve compression Prior to us, there had not been a model for chronic nerve compression, and we worked with rats and subhuman primates to develop a model for chronic nerve compression. And this model has been reported and demonstrated progressive thinning of the myelin of the nerve fibers over time, which is you would expect with chronic nerve compression. We then worked with the double crush hypothesis and in diabetic rats made diabetic with streptozotocin to look at whether nerves in general are susceptible to compression at 2 sites, and in particular whether the diabetic nerve is susceptible to compression. And we did document that the double crush hypothesis worked in the animal model. Upton and McComas had said in 1973 that underlying metabolic neuropathy like diabetes might serve as the first crush to make a nerve susceptible to compression. And then we worked in diabetic rat models and demonstrated that this was true. Why is the diabetic nerve susceptible to compression? The most important reason is that the nerve is swollen. If you take a nerve and put it in a tight anatomic place and the nerve swells in a known area of anatomic narrowing, we would expect a relative degree of compression to occur. This was not my work. It's been documented by many people, but in the normal rat sciatic nerve, we see in this column particular size of the nerve, and under the same magnification, the diabetic rat, the nerve is swollen. There is subperineural edema. There is endoneurial edema. Glucose gets metabolized to sorbitol, which likes water and pulls water into the nerve. So we have endoneurial edema as the primary cause for the nerve to be susceptible. There is so decreased axoplasmic flow, and it's the slow component of anterograde flow, meaning the nerve cannot repair itself well because it cannot transport structural proteins. There's also the well-known glycosylation of collagen. As glucose binds to collagen, the nerve becomes stiffer, the tunnels become smaller, again making the nerve susceptible to compression. As a surgeon, I can't change any of these things. A surgeon cannot change an underlying metabolic neuropathy. A surgeon's a technician. We can open up a tight place, and that is all I'm saying that we are doing. Let's look at perhaps the most important study that I did in the animal models. How can we ask a small rat if he has diabetic neuropathy? We can look at his footprints, and you can tell by footprints if there's a difference between normal and if this footprint, which might be deeper in the sand because the animal's heavier, or this one which is deformed because of injury or disease. And the rat footprint can be obtained by placing the foot in colored watercolor paints, and having the animal run down a white piece of typing paper to a dark area where he feels secure, and we can then measure the footprint. We can digitize it on a computer and measure print length, toe spread, intermediate toe spread, and see how that changes with disease. And this was published first in 1991 as a model, and in rats made diabetic, streptozotocin, 1 injection raises their blood sugar to 400, and if you look along the bottom, this is 1 year. Blue are our normal weight-controlled non-diabetic rats, and with 1 injection, the blood sugar goes up, and over time, the print length continues to get longer. In some animals with only a single injection, the blood sugar returns to normal, and we see the print length return to normal. And we felt then that this was a good model for studying neuropathic walking track patterns. And so how do we test our hypothesis? We take a group of rats and have to remove the site of anatomic compression. That is to say, we'll take the heel under the microscope and open the tarsal tunnel, identifying the medial and lateral plantar and calcaneal nerves. So we create a group of rats that do not have a site for anatomic narrowing. We'll then make this group of rats diabetic and compare them to another group of rats that are diabetic that still have a tarsal tunnel. And here is that study. This group of rats has an intact tarsal tunnel. Again, notice the study is year-long. White are the normal, non-diabetic rat walking track pattern. In this group of rats that have an intact tarsal tunnel with blood sugars of 400, over the year their print length increases, toe spread increases, intermediate toe spread increases, and this is our neuropathic walking track pattern. In contrast, the animals who have no tarsal tunnel for a period of a year with blood sugars of 400 walk with a pattern indistinguishable from the non-diabetic rats. This demonstrated that release of the tarsal tunnel, or the absence of a site of compression, prevented the neuropathic walking track pattern from happening and gave us our first real insight in the experimental model that we could alter the natural history. This work has been documented again and confirmed by a group of plastic surgeons in Turkey and recently from a group of plastic surgeons at the Cleveland Clinic. Let's just review all the basic research science we just showed you. Models were developed to identify chronic nerve compression and understand what that does. This was evaluated in the double crush model in diabetics and non-diabetic rats. We demonstrated that the diabetic rat was susceptible to compression. We've also looked at the histopathology of primate diabetes, which we did not have time to show you today, and we showed you the most important study that in the rat diabetic model, without a site of anatomic compression, a neuropathic walking track pattern did not develop. Let's go back then to the clinical area and taking care of our patients. Let's look at some prospective non-blinded studies. In 1995 and in the year 2000, two surgeons who did not train with me began to use our work. They chose people who had nerve compressions identified by a positive Tinel sign. Their patients were much more advanced. Some of them had ulcers, some of them had amputations. They still were able to obtain good relief of pain in these patients, and with the number of ulcerations, we would expect 50 to 60% to recur. They had only 3% recur because sensibility was restored. Subsequent to that, we have papers from a group of podiatrists in Chicago, an orthopedic foot and ankle surgeon in Michigan, a neurosurgeon from the University of Arizona reviewing the results of my partner, Dr. Maloney here, a podiatric foot and ankle surgeon from Indiana, and we see all patients being chosen without ulcers or amputations with a positive Tinel sign using similar outcome measures. None of these patients have had a new ulceration or amputation. Last year, in the year 2006, this group of reports appeared, again with the same indications for surgery, the same type of magnitude of improvement, and the same type of outcome in terms of ulcers or amputations. This work is being done in India, China, and Turkey with the same degree of results. Overall, if you would accept that a meta-analysis could be done of that group of diverse studies, which total 833 patients, the magnitude of improvement is 80% for relief of pain, restoration of sensation, and no new ulcers or amputations. I'd like to share with you this study, which I think is very important. Sometimes the work has been criticized as the fact that, well, patients don't really get better. They're in a study and now their blood sugar is the best it's ever been. We have a group of patients that we were following, and for one reason or another, they did not come back to have their opposite leg operated on. We therefore have a group of patients who've had surgery in one leg. The blood sugar would be the same in both the left and right leg. They had no new ulcers or amputations. What would you think would happen to the contralateral leg? The hypothesis was that operated extremities were equally likely to develop unfavorable outcomes as non-operated extremities. Here's an example. This patient is 3 years after having tarsal tunnel decompression. This side has not been operated on. It clearly has lost a toe and has a new dorsal ulceration. On average, the patients were followed 4.5 years, some for 7 years. Here's another example. 7 years after surgery, no ulcer, no amputation. The opposite leg is missing 2 toes and has osteomyelitis. What did we find? We found 12 new ulcers and 3 amputations in the opposite leg. Statistically analyzed, this was a significant difference. This suggests that the natural history of diabetic neuropathy can be changed by decompression of peripheral nerves. This is similar to what we showed in the basic science model in the diabetic rat. What about balance and falls? It's sort of intuitive. If you don't have much feeling in your feet, you'll lose your balance. And in 2004, we actually reported this. We have a method of measuring sensibility, which we discussed with you, the pressure-specified sensory device. We go back to that childhood game. If your eyes are open on a foot plate on the floor that acquires signals continuously. We can come up with our center of gravity. When your eyes are closed and you rely on sensibility just from your feet, we show very little difference here. So with normal sensibility, we have very little sway and normal balance. In the diabetic, where we have loss of two-point discrimination in the perineal and tibial nerve system, we have, with the eye open, still a wider center of gravity. And when the eyes are closed, this big difference, which is sway, which represents loss of balance. And when that study was looked at, we showed it would predict that diabetics have less sensibility than normals if they have neuropathy, and a change in their balance. Now let's go to our hypothesis. Decompression of the tibial nerve in the tarsal tunnels bilaterally will improve sensation and balance in patients with diabetic neuropathy and superimposed nerve compressions. Here's that patient prior to surgery. Here's the patient after surgery with two-point discrimination having been recovered after decompression of both legs. This is after 3 months after surgery in one leg and 6 months after the other. We now see that very little difference with the eyes open and the eyes closed. And when the study is evaluated, as reported last year, we showed that there was a significant improvement in sensibility and an improvement in balance. This should translate into less falls, less broken hips, less fractures. On the internet today, if you look up neuropathyregistry.com, there's a multi-centered prospective study with patients all trained in using the same criteria. There have been no new fractures reported in this group of patients. What about infections? Recently given the best possible care, and these are current leading experts in the world of podiatric foot and ankle surgery, reported in diabetes care. 1,666 patients followed for 2 years. 9.1% were admitted to the hospital with foot infections. In our data in the multi-center prospective study today, with 737 patients followed for 3 years, we have 0.9% admitted for foot infections. Which patient would be the ideal candidate for surgery? The patient has to have symptoms. They have a diabetic neuropathy as determined by their medical doctors and the typical instruments you would all know. They should have their sugar under the best possible control. If they have pain, they already should have failed neuropathic pain medication. They should not have swollen feet. They should have neurosensory testing done to document the neuropathy and stage the degree of neuropathy. They should have adequate circulation so we know healing is possible. They should have a positive Tinel sign. This is a very important sign, and let me diverge just for a minute. Here's what I'm not saying. I am not saying that all diabetics with neuropathy should have a Dellon triple nerve decompression. I'm saying that if there are superimposed nerve compressions in a patient with an underlying neuropathy, that patient should have a nerve decompression. Positive Tinel sign we've reported in a prospective study in December of 2004. What is the prognostic value of a positive Tinel sign? We began the study in 1997. We dichotomized it into the presence or absence of a Tinel sign and looked at the outcome at 1 year. In 46 patients with diabetics, with the result dichotomized into good or excellent or failure, a positive Tinel sign had a 92% positive predictive value of patients obtaining a good to excellent result from this surgery. The physical examination with a positive Tinel sign is critically important. Interestingly enough, in the classic academic neurologic approach to examining the patient, Tinel signs are not typically searched for. We need to introduce this into our examination of our patients. We're here today because we're interested in saving the diabetic foot. The future holds great promise for improving patient care if we can effectively translate the information we've learned in the laboratory and in clinical science to widespread community practice, which is why this telecast today is going out to the community of the state of Arizona at large. Who should do this surgery? Decompression of peripheral nerves in the lower extremities should be done by board-eligible surgeons already in practice who have taken appropriate postgraduate CME-approved training in this surgery. We offer workshops for this, and just weeks ago at the University of Arizona, we had one of these intensive learning sessions, which is a day of lectures, a day of cadaver dissections, and a day of live surgery. To date, 310 surgeons have been trained by myself doing this work in 43 states and in 18 countries in the world. On neuropathyregistry.com, and we're coming to the end of this talk, you can look at various outcomes, primary and secondary outcomes. Let's just take a look. Here we're going to look at sensation. Here is normal sensation. Here is essentially absent sensation. When patients enter the study on average, they come in at this level. So far we have acquired 752 operations and 555 diabetics, a total of 1,000 patients. This means that many patients with neuropathy unrelated to diabetes have the same results generalized to them. There are supposedly as many people in America today with neuropathy of unknown cause as there are diabetics. In a recent study, perhaps 40% of those patients with neuropathy, unknown cause, actually are found to have glucose intolerance. So in time, they will likely become diabetic. Here we see progressive improvement in sensation following surgery. Here we see that this goes out 1, 2, 3, 4, 5, and some patients have been followed for 10 years. What about pain? Typically, the patient enters the study with pain at a level of 8.5. Although some neurology reports suggest 10% of diabetics have painful neuropathy, probably 80% of those who come to see us have associated pain. Here, by 6 months, the pain level has dropped to 2.5. Once the nerve is no longer compressed, even though the underlying neuropathy is still present, the pain is improved. And this pain improvement is long-lasting. What if someone is a diabetic and has not had a previous ulcer? What do we expect? We expect 1 out of 6, or about 15%, to have a new ulcer. In green at the bottom is, in fact, what we're getting in these patients who've had sensation restored, which is essentially no new ulcerations. What if they'd had a previous ulcer? If someone's had a previous ulcer, we can expect half of them to recur. In fact, what we're getting now, and we only have 44 patients in this group, is a great reduction because sensibility has been recovered. You can view this at decreased costs for patient care. We have no amputations in any of the patients. And finally, maybe we can have a patient speak to us, and I'm hopeful that the sound work.
Has it been since you could feel your feet?
About a year.
About a year?
Yes.
Let's have your sister touch your right foot, which didn't have surgery yet. See if you can feel that much.
No, I can't feel that.
No? Now let's see what happens when she touches your other foot. You just had that surgery yesterday, right?
Yes.
What happens there?
Yes. Yes.
Okay.
I'd like to thank you for listening to this presentation today and emphasize that I believe we now have some hope for people with symptoms of neuropathy if we will examine them to see if they have the presence of underlying nerve compressions, because we have the ability now to decompress nerves in these people, restoring sensation, relieving pain, and if that happens, we can prevent ulcers and amputations, we can restore balance, might even create peace in the world. Thank you for listening today. Do we have any questions? Yes, sir.
Your patient series that had the unilateral decompression, did you also control for peripheral vascular disease because of the common association of peripheral vascular disease with diabetes?
Yes. That's a good question, and we did not actually test each of their legs at the time we called them to see whether it had any new ulcers or amputations. The patients all have sufficient circulation to heal their wounds. We test them prior to surgery with their pulse, their brachial index, and those where we're concerned about the circulation have a vascular workup to see if they need to be bypassed. This group of patients that you mentioned, we called them to ask how one leg had compared to the other in terms of ulcers or amputations. Do we have another question?
So is there a difference in how patients do with or without having had a bypass?
The question was, is there a difference in how patients do if they have or haven't had a bypass? Well, we won't I guess it's fair to say we've had only very few patients come to us who've had previous bypasses to have the surgery. We have 1 or 2 patients who we felt did not have good circulation who were bypassed, and we operated on them. There haven't been enough in that group really to look at as a separate subgroup, but it's very critical, as I said in one of the slides on choosing the patient, that we know that they have sufficient circulation to heal. But if a leg's been revascularized, just as we could take someone whose heart's been revascularized and put them to sleep and operate on them safely, if the leg's been revascularized, we would anticipate that we could get healing in that leg, but we have not studied as a separate group, no. Well, I wonder, many of you in the room are neurologists. Is that not correct? So I wonder if any of you would have a comment on whether you would begin to use a Tinel sign in your classic evaluation of patients that you see for neuropathy to look for an underlying compression. Would any of you have any comments on that?
Well, I think we usually do attempt to Tinel sign at the wrist and the elbow.
Yes.
In my own practice, I can say I've never attempted to do one in the foot. I don't know exactly how I would do that. But I would generally say that with respect to carpal tunnel syndrome, Tinel sign is not very reliable, neither is phalanx, for example, compared to doing conduction studies. So I think we rely much more on conduction studies and characteristic blocks.
Yes. So there's actually a huge problem with identifying, I think perhaps you would agree there's a problem in identifying underlying nerve compressions in the presence of neuropathy. Vera Brill, who I think you know is a very accomplished neurologist in Toronto, published Diabetes Care 2 years ago, that in the presence of diabetic neuropathy in the hand, where your testing is the most accurate, they actually could not distinguish diabetics with neuropathy from diabetics without neuropathy, whether they did or didn't have carpal tunnel syndrome present. And they recommended, that was done with Toronto, the Joslin group in Boston, and the Harvard statisticians, that patients examined by physical examination to identify underlying nerve compressions. And it's very difficult to do it in the tarsal tunnel region in terms of electrodiagnostic testing. So to answer your question, which is great that you look for carpal tunnel in the hand and cubital tunnel in the foot, in the elbow, and I can't really get my ankle up here, but if you just take your hand and do the same thing between the medial malleolus and the calcaneus, and you see tingling into the leg, is all you have to do. What do you think the basis for a Tinel sign would be in a patient? You said it isn't reliable. I mean, if I tapped your elbow and you felt it in your little finger, is that abnormal or normal? What do you think that would mean?
I'm not speaking to the specificity. I think the problem is that the number of people who have the sign compared to the number of people who have conduction block with the characteristic carpal tunnel is a relatively small segment of the individuals. It's like looking for weakness or atrophy in the hand. Once you've seen that already, you're looking at the tip of the iceberg.
Right. Well, I think a wonderful thing that you might wish to do in an academic center like this is with one of your residents, begin taking a group of patients with neuropathy, diabetic or otherwise, and looking for the presence of Tinel signs in the common peroneal nerve at the knee or the tibial nerve in the tarsal tunnel, and simply describing how often those are there, and if they're there, perhaps doing the exact electrodiagnostic studies. And perhaps you'd like to try Kimura's inching technique in the hand to the tibial nerve in the tarsal tunnel to see if you could increase your identification of an underlying compression. Because if the neurologist could agree on how we can identify these underlying nerve compressions, we would have a way of referring patients for the appropriate nerve decompressions. And so I would look forward to a group of neurologists actually tackling that subject. Have any other questions? Okay, I guess we're perfectly clear. Well, thank you very much for listening.